Okay, so the FEBOS-CR is an all-in-one device composed of a topographer, similar to the MERS-39, and an open-field ocular aberrometer. Open field, not closed field like the series, that we have been listening along this session. So the idea is that with the open field aberrometer and the topographer, all this biometric data is going to feed a new software that we are developing together with CSO in order to make a virtual eye from the real eye, to create in the system a virtual eye that is going to simulate how the light rays are going to go through the eye system. So with that information, we can simulate what is going to happen in the eye and the visual quality with different surgical procedures. So basically, the purpose is to try to understand what is going to be, what we are going to do in the eye, and then predict the outcome in order to select what is the best surgery for each specific patient according to his or her real eye. So this is a project that is granted by the European Union, and is in collaboration between us, CSO, and also with the assistance of the Jorge University in Denmark and the Centro Hospitalario of Coimbra in Portugal. So the idea is, then we take the patient, we do all this preparative analysis with the MERS-39 and new open field ocular aberrometer, and then with that information, we're going to simulate what is going to happen to the eye and the quality of vision by different either laser corneal surgery procedure or intraocular procedures with premium intraocular lenses. And so with that, the idea is to have not subjective information, but objective information about what we're going to get, and then to assist what is going to be the best surgical option for the patient. So then the surgical decision doesn't rely on the subjective opinion of the surgeon, but in objective data about what is going to be better for the patient. So what I'm going to show you, this is preliminary data, okay? So this technology is not yet ready, okay? We're working on it, it's being developed, and I'm going to show you some preliminary data about what we're going to have with this new technology. That is the FEBOS-CR and the OFA, that is the open field aberrometer. So the FEBOS-CR, the first thing it does that the current MERS-39 doesn't is to measure the axial length. Okay, now it does measure the axial length. So now, of course, we need to prove that this axial length measurement is actually accurate. So, and then we are validating that using as the gold standard measurement the IOLMaster 700. So in this first analysis, we took 87 eyes of 87 patients, and we divided them according to the axial length. Those patients with long axial length, longer than 26 millimeters, normal axial length eyes under 26, and a few cases of cataract. And then we're going to compare the axial length given by the device with the axial length given by the IOLMaster. And here you have the measurements, but just for question of time, I'm going to show you directly the differences. So basically, in normal eyes, those with axial length under 26, actually the device works very well. If you see the main difference between the IOLMaster 700 measurement and the FEBOS-CR measurement in normal eyes, that is the group 2, is here, this doesn't work, is 0.016 millimeters difference, being this different, not statistically significant. It's true that if we go with longer eyes, longer than 26 millimeters, this difference between the IOLMaster and the FEBOS-CR is slightly larger, 0.03, although we believe that this is not clinically relevant, although in the next few months, we need to prove that. We need to take this axial length measurement and see what was the IOL power prediction by one device, by the other, and then see the postoperative outcome, and then see which one of the devices was actually more accurate in order to prove that this small difference in the axial length measurement, it is actually not clinically relevant. That is what we actually think. Nevertheless, the correlation coefficient between both devices is actually 99% in the axial length measurement. So here we have So this is in cataract patients. So what I have just shown is the axial length accuracy between IOLMaster and FEBOS in normal patients with long or not axial length, but normal patients. What happens if the patient has a cataract? This is something that we need to keep working, because if we take patients with cataract, the difference in the axial length measurement between IOLMaster and FEBOS is greater, is 0.4 millimeters. And probably this is going to be clinically relevant, and we need to work harder on this, because probably the fact of the lack of transparency made and induced by the cataract is creating probably some interference in the measurement, creating this greater difference in the axial length. Looked at in the group 2, that is the normalized, the difference between the two devices was 0.01, while if the cataract is present, the difference is 0.0. So probably clinically relevant, and this needs to be upgraded in the near future. So as a first conclusion regarding the axial measurement, we can say that if we're dealing with normalized, without cataract or transparency problems, in patients with normal axial length below 26, the device works very well, works perfect. In patients with longer axial length, it works very well, but this difference of 0.03 needs to be, we need to demonstrate that it's not clinically relevant and it's not affecting the IOL power measurement. And in patients with cataract and loss of transparency in the media, probably we need to work harder in order to get more reliable outcomes and then measurements. So this is the first validation. So if the axial length measurement of the FEBOS works or not. So this was the data. Now, the next validation is how it works, the open field aberrometer, okay? Because with the Paramis or the SIRIS, it's a closed field aberrometer. So basically, it's an ocular wavefront, but the patient is looking at the device. So there's gonna be some accommodative influence. The patient is gonna be accommodating, and this is gonna be artifacting part of the measurements. So here, the idea of the open field aberrometer is that the patient is not looking at the device, it's looking through a mirror at a long distance target. So the accommodation artifact is lost, and so the measurement is going to be much more reliable. But in order to prove that, of course, we are validating this. We took 30 eyes from 35 eyes from the same number of patients, normal patients, okay, normal patients, no problems of the eye, in the eye, no accommodative problems, anything. And then we did 3 measurements: subjective refraction by the optician, the refraction given by the open field aberrometer, the OFA, and the refraction given by the closed field aberrometer, the OSIRIS, to see how are the differences. So in the first table on the upper sector, you can see the difference between subjective refraction and the OFA, the open field aberrometer, and you can see actually that is pretty accurate. So the values of the sphere, cylinder, and spherical equivalent given by the OFA were pretty similar, almost the same as the subjective refraction, and the differences were not statistically significant. So actually, the measurement was pretty accurate and almost equal to subjective refraction by experienced opticians. While we do, the lower table is the same refraction against the refraction given by the OSIRIS, and you can see that here there are statistically significant differences because the OSIRIS is giving you more myopic outcomes, actually half diopter more myopic than what you get with subjective refraction. And this is the artifact induced by accommodation. With the Paramis, the OSIRIS, you are looking at the device, there is tonic accommodation, and this is creating a more myopic measurement that this actually is not true. So with the new open field, we are making a new value and an upgrade on the measurement of the ocular wavefront because we are removing the artifact given by the tonic accommodation during the measurement. And actually, when we compare the lower order aberration and the higher aberration between the two devices, of course, we get what we were expecting. So you know the lower order aberration is the refraction, is influenced by the sphere. And so if we see the lower aberrations between the OFA and the OSIRIS, the results were statistically significantly different because we're higher in the OSIRIS, again, influenced by the more myopic outcome influenced by the accommodation. While in the higher aberration, we didn't get a statistically significant difference between the measurement between the two ocular wavefront devices. So the refractive measurements provided by the new open field aberrometer presented suitable agreement with subjective refraction. So basically, subjective refraction, open field aberrometer measurement equal. Not the same if we use the OSIRIS, that is a closed field aberrometer, because of, as I said, the influence by the tonic accommodation during the measurement because of the closed field format. And then, just to finish the presentation, so this is what I've shown is the validation of the device. The device does work, what we are doing makes sense, is the OFA working, is the axial length accurate, but this is just the steps that we need to move in order to get the target, the final target, and the final purpose of this device, that is to simulate what we're going to get in a patient after surgery. And this is just a few examples, okay? This is early This is early evidence, okay? So don't take this as final data, but here you have some examples. For example, this is a patient of minus 5.5 diopters, okay, minimal cylinder, and in the input data you have some of the measurements taken by the device. So the device, what it's gonna do is it's gonna take all this biometric information, create and simulate like virtually what the eye, so the eye for the patient is gonna virtually create it, and then it's gonna understand how the light rays are going through that specific eye of that specific patient. And then it's gonna, with that virtual eye model, it's gonna simulate the surgery, in this case a LASIK, with all the variations induced by the thinning of the central thinning of the pachymetry, the spherical aberration, coma, blah, blah, blah. And it's gonna tell you what is the expected PSF, the ocular quality, the quality of the vision in this patient after surgery. And here you can see before surgery, the PSF, in the patient with myopia, with this 5.5 myopia, and what is the expected PSF after surgery, after this LASIK surgery. And the CSF, that is another way of understanding the quality of vision, the dashed red line would be like the ideal perfect CSF, and the blue line is the actual quality of vision of the patient. Before surgery, of course, without glasses, very poor, and after surgery, it's gonna get much better and closer to the perfect one. Of course, it's not going to be perfect because no eye system is actually perfect. We are imperfect as nature, and this is the reason why we are getting better, but it will never be perfect. So this is for LASIK, but as well, the idea is to not only simulate what is going to be the outcome after laser surgery, but also after cataract surgery with premium lenses. And this is probably the most important thing. You have a patient, the patient is wishing for a premium lens, and you don't know which really lens fits better to that specific eye. A BBT, a trifocal, an enhanced monofocal. Now, you know, we have many type of lenses, intraocular lenses in the market. So the idea, the purpose of this project is just you have the ocular wavefront measurement before surgery, and then it's gonna predict what is gonna be the quality of vision with all the different multifocal lenses in that specific eye, in order to tell you, look, this eye with this pupil, this cornea, this axial length, if you put a BBT, it's not going to work, so better put another lens. Or if you put a trifocal, actually you are doing good. So basically to try to have objective criteria in order to select the best patient for the best IOL for each specific patient. So you don't need to just guess and try to decide according to magic, as we do sometimes now. So, and this is another simulation. This is the PSF of the patient before surgery in a patient with cataract. And this is the prediction of what is going to be the quality of vision, the PSF, after surgery with the Technic Symphony and the BBT. And you can see the differences in the PSF, and that is a reflection of the quality of vision, and the same graphs as before with the CSF, how is the quality of vision before surgery and after surgery, improving the quality of vision, okay, being different between the Technics and the BBT. You can see that the BBT is slightly worse, but this is expected because the BBT is an EDOF lens, it's a real EDOF lens, and this real EDOF lens basically creates intraocular aberrations that affect the quality of vision but increase the range of focus, while the Technic Symphony is just a low-power diffractive IOL and is expected to have better values of PSF. Other thing will be the quality of the photic phenomena. But this is just a simulation, okay? This is early data, this is still not validated. We are working on that, we're working to make it better, to make it reliable, in order to provide useful information. In the future, we'll put more. We have several intraocular lenses. The idea is to have all of them, and also to predict not only the outcomes with LASIK, but also with SMILE and the rest of laser corneal techniques. So the software is increasingly getting closer to more real and promising results, although, as I said, we are still working on it. The intention is to simulate all premium lenses, all laser refractive surgery procedure, in order to give you reliable data, in order to help you to select what is the best approach for each specific patient regarding what is going to be the expected postoperative quality of vision. And of course, this will require validation. We'll need to do these predictions and then later do surgery in the patients, do the measurements after surgery, and then see if the prediction of the FEBOS, the new FEBOS AXL, is actually real and accurate to what is the later postoperative real outcome. It's still not done. We're working on that, and hopefully every year we'll be able to provide you updated results. Thank you very much.